Welcome to the C's Group training for documenting medical necessity for cataract surgery. This training is required for all front desk personnel, technicians, scribes, and surgery schedulers. Medicare gives us specific information about what documentation it expects to see in our medical records to support the claim that a cataract surgery, whether single-side or bilateral, is medically necessary. This information is contained in a local coverage determination. Medicare engages a Medicare Administrative Contractor, or MAC, for each jurisdiction in the United States. The MAC for Tennessee, Georgia, and Alabama is Palmetto GBA. Keep in mind that each MAC may have unique requirements for documentation of medical necessity for the same procedure. The LCD does not have to be the same across the country. Thus, it is very important to know the contents of the LCD that governs your geographic area. The LCD for our area is LCD L34413. If required elements of documentation from the LCD are missing from a chart, denial of payments is a foregone conclusion should that chart be reviewed by Palmetto or another auditor working on behalf of Medicare. Recent enforcement activities in Kentucky and Ohio show that many providers are vulnerable due to lack of complete documentation within cataract evaluations. Some providers have error rates as high as 88.7% simply because pieces of documentation required by the LCD were not in the chart, and physician practices and ASCs have repaid millions to Medicare. The key takeaway from these recent governmental audits is this: missing documentation equals a de facto finding of a lack of medical necessity. We must be very diligent to satisfy the LCD documentation requirements. LCD L34414 should be read as an algorithm. The first decision to be made is the reason the cataract surgery is necessary in the first place. This reason will typically be one of 6 conditions listed in the LCD itself. Those conditions are listed on this slide and the next slide. All staff should be familiar with these 6 different conditions for medical necessity. Medicare notes that it may consider other reasons for cataract surgery if those reasons can be asserted to prove medical necessity and if, based upon those assertions, the treatment of cataract surgery is compatible with accepted standards of care. The majority of our cataract surgeries are done based upon a patient's complaint of a symptomatic cataract that causes impairment, resulting in functional limitation. The documentation standards for this complaint are set out in 2 sections of the LCD, and we must be sure to capture documentation that satisfies the requirements of both LCD sections, not only the first section. Once we have determined that cataract surgery is medically necessary due to functional impairment or limited activities of daily living, we must then graduate to the second part of the LCD, which addresses the required documentation elements that must be present in the patient's chart in order to support medical necessity. There are 3 elements of required documentation, and all 3 must be captured within the medical record for each eye upon which a cataract surgery will be performed. Many cataract surgical practices satisfy the first impairment documentation requirement by having the patient complete a visual activities questionnaire. A statement that there are no non-operative treatments for the symptomatic cataract must be included in the supporting documentation. This language should be supplied by the practitioner who completes the cataract evaluation and is available for selection in the plan section. Lastly, there must be a current best corrected visual acuity recorded in the chart, either distance or near, with special attention paid to near refraction if the primary impairment reported by the patient is near related. This refraction must be performed by the surgeon or the staff within the surgeon's office who is qualified to perform the refraction under state law. Remember that the majority of our cases fall into the symptomatic cataract category, so it is very important that we document all the required elements for this type of surgery correctly. The first required statement is a statement of specific symptomatic impairment that results in specific function impairment or activity reduction. How do we document specifics? Under the new Palmetto LCD, we must pay close attention to our documentation to ensure it is at the level of specificity required by Medicare. We must first document a specific symptomatic impairment. This is often given as the patient's chief complaint. Most common complaints given include blurriness, decreased vision, or double vision. Once we establish the complaint, we then elicit how that symptom is impairing the patient's ability to function. Does the blurriness or glare make it difficult for the patient to read or drive? Be specific in how the patient's ability to perform the activities of daily living are being limited or impaired. It is very important that if the tech is unable to elicit a complaint from the patient, that the tech not only document this in the patient chart, but the tech should also verbally alert the physician that he or she has been unable to elicit a complaint from the patient. The physician might be successful in doing so, but if not, we are then able to advise the patient that it might not be time yet for cataract surgery. So, how are we going to make sure our documentation is specific enough? By adding some new tools to our belt and better understanding the ones that we already have. First, we will be adding a patient questionnaire to all check-in packets for new cataract evaluation patients. Next, we will look at the capabilities of our electronic medical records to capture the required information. Lastly, we will look at a revised booking slip for cataract surgery that will allow our surgery schedulers to ensure our documentation is complete and correct before the surgery is performed. The pre-surgical cataract patient questionnaire will be included in the check-in documents for every new cataract evaluation patient. Each new cataract evaluation patient should be asked to present for his or her appointment 10 to 15 minutes early so the patient may complete the questionnaire. The patient will complete the form and hand off to the tech beginning the patient's evaluation. The tech will verbally verify the information in the questionnaire and note any discrepancies. The questionnaire will then be scanned into the legal medical record for the patient. The pre-surgical cataract patient questionnaire is a newly standardized form that is to be used across the enterprise. Please destroy any such forms created before January 1st, 2019 and replace those forms with newly created forms available from your center director. Patients will be asked to document how their limited vision is actually impacting their ability to carry out the activities of daily living. This tool allows us to fulfill this LCD requirement that functional impairment be communicated in the patient's own words. The patient will be asked to relate his or her symptoms, which will likely align with the patient's chief complaint taken during the HPI. One of the most profound losses of function is related to the patient's ability to drive, especially the ability to drive at night. Because the ability to drive impacts so many other activities of daily living, the patient is asked to document if he or she drives a car. If the patient still drives, then is driving undertaken with difficulty? And for those patients who have ceased to drive, we want to document how long ago the patient stopped driving. Lifestyle questions give us insight into how the patient wants to function after surgery, as well as how motivated the patient is to reach his or her post-surgical goals. This information gained through the questions shown here can help us better manage the patient's expectations regarding the surgical outcome and any challenges that may be encountered reaching that outcome. Please ensure the patient's signature block is completed. This portion of the questionnaire allows us to document the patient's stated desire to proceed with surgery when medically necessary, as well as to affirm that all the information given in the form was supplied by the patient. So how do we capture this information within our electronic medical records? Within IMD, the tech will select the patient's chief complaint or symptom. In this example, we have chosen blurry vision. By selecting blurry vision, we are then given another screen that contains options for quality, modifying factors, context, and associated signs and symptoms. All fields should be completed based upon patient interaction and verification of the patient's responses in the patient questionnaire. Now that we have selected the chief complaint and added the quality, modifying factors, context, and associated signs and symptoms, text may add additional pertinent information in the free text field titled HPI letter text. In the example shown, you will note that the tech has painted a picture surrounding the difficulties the patient faces when driving and faced with glare. Use this free text feature within IMD to tell a story of the patient's symptoms and how those symptoms are impairing the patient's function. This slide demonstrates how we capture this same information in Greenway. Here we see the Greenway screen in which a tech completes the HPI for a cataract evaluation. Note that this slide in Greenway allows the tech to document reported impairments as a patient statement. Remember that the majority of our cases fall into the symptomatic cataract category, so it is very important that we document all the required elements for this type of surgery correctly. Required statement number 2 states a current best corrected Snellen visual acuity must be recorded at distance or near if primary visual impairment is near. How is this information captured in IMD? We will be doing a refraction during each cataract evaluation, and the results will be put into the appropriate screen for capturing refraction information. Remember that if the patient's reported primary visual impairment is near, a near refraction must be included in this screen. The patient's current prescription or uncorrected visual acuity will not satisfy this LCD requirement. Note the location for documenting a current best corrected visual acuity within IMD. Although there is no black and white visual acuity threshold within the Palmetto LCD, we do have insight to know that Palmetto looks at visual acuity as a single piece of many pieces of information when determining medical necessity. Additionally, patients with visual acuity of 20/40 or less should have additional testing, typically glare testing, to establish that there are other factors at play that are contributing to the patient's impairment than visual acuity alone. Note the location for documenting glare within IMD. For those using Greenway, this slide demonstrates where a current best corrected visual acuity is entered in Greenway. The last required statement for symptomatic cataract is a statement that the patient's visual function is not correctable by a tolerable change to the patient's glasses, contact lenses, or other visual aids, thus making cataract surgery necessary so the patient may function at his or her desired level while carrying out the activities of daily living. Note that this third statement is a statement that must be made by the physician, since judgments regarding whether a procedure is medically necessary or not may only be made by a physician, as physician is defined under the Social Security Act. For our purposes, both medical doctors and optometrists practicing within the scope of their state licensure meet the government's definition of physician under the Social Security Act. A similar statement as the one shown here is being added to IMD, so physicians may include this information in their plan prior to medical record signature. There are times when other ocular diseases are present, and in order to effectively treat or monitor those diseases, the cataract must first be removed. CMS expects this situation to be clearly indicated in the medical record, with specific information as to why the removal of the cataract is necessary to treat the other ocular disease. For example, cataracts might need to be removed in order to appropriately monitor diabetic retinopathy. If that is the case, then CMS expects explicit language to be in the medical record explaining those circumstances. The informed consent process, not necessarily the informed consent form, must also make clear to the patient that the cataract is being removed to monitor or treat the other ocular disease, and there must be a statement in the medical record that the patient understands that the removal of the cataract in this type of situation is not expected to significantly improve the patient's vision. One indication for surgery is that the cataract must be removed to establish clear media to monitor or treat other ocular disease. In this case, the cataract might not be causing major symptoms, but it is hindering the ability of the physician to adequately treat or monitor the concomitant eye disease and thus must be removed. The example shown is from Greenway EHR. Similar statements are being added to IMD so the physician may appropriately select the correct statement. In some situations, when patients have cataracts and another ocular disease, removal of the cataract may result in moderate but not significant improvement in the patient's vision. When that is the case, a statement similar to the statement shown above will be made in the medical record. Remember that ancillary tests are an important part of the documentation we use to establish medical necessity. Therefore, it is important that we document all appropriate types of ancillary tests performed to establish the need for the cataract surgery. The interpretation or impression from the test must also be included in the medical record, and the interpreting physician's signature must be present in the medical record. Remember that under LCD L34414, cataract surgery may only be performed upon patients with an approved diagnosis. Since most of these surgeries are age-related, we will often be using diagnosis from the first group of diagnosis codes, H2511, H2512, or H2513. However, there is a second group of codes that may be used when the cataract density does not appear to make removal of the cataract necessary, but cataract surgery must still be undertaken due to other ocular disease processes. The surgeon must also select the appropriate CPT code for the surgical procedure to be performed. The description of the diagnosis and the description of the surgical procedure to be performed should match in both the surgeon's practice record and the surgical site's informed consent, with the only exception being unforeseen procedures that become necessary due to medical complications. Don't forget that Medicare lays out very specific physician signature requirements. By applying his or her signature, a surgeon is saying to CMS that he or she has reviewed the medical record, authenticated that the medical record is complete and accurate and should be relied upon by Medicare to pay the surgical claim. Remember, if there are documentation errors or billing errors due to a failure to document medical necessity, the surgeon Because we are introducing new processes and new documentation elements, we will be monitoring these changes over the coming weeks. One of the ways we will do so includes a change in our booking slips for cataract surgery and our surgery schedulers acting as gatekeepers to ensure that surgical charts contain all required documentation before the chart is printed and sent forward to the surgery site. We have modified our existing surgery booking slip to accomplish this purpose. The first page of the booking slip will remain largely unchanged. The example shown is from Southeast Eye in Chattanooga. However, each clinic location will modify its booking slip to include the possible surgeon choices and to include the correct logo. The surgery scheduler will verify the chief complaint, the refraction and glare measurements are present in the chart. The last question on the patient questionnaire will tell us if the patient can no longer function at his or her current vision level, and the physician's plan should contain a statement that non-surgical options are not viable solutions, along with the fact that the patient has been informed of the risks, benefits, and alternatives to cataract surgery and still wishes to proceed with the surgery. On page 2, section 2 of the booking slip, we will see possible indications for surgery. The indication for surgery is telling us why we are doing the surgery. Do we expect significant visual improvement due to the removal of a symptomatic cataract? Do we expect partial visual improvement after the cataract is gone due to another ocular disease? Or are we having to remove the cataract to obtain clear media to monitor or treat another ocular disease? One of the 3 reasons noted above will be found in the physician's plan. The last section in the booking slip allows the surgical scheduler to select why the surgery is medically necessary. There are 5 possible reasons to choose from. Remember that if you are selecting symptomatic cataract, you should also check the chart to make sure the limitations of activities of daily living, best corrected visual acuity, and glare testing are documented appropriately. The reasons why cataract surgery may be medically necessary are contained in this slide, with the most common reason being significant visual impairment due to symptomatic cataract. By looking at the chief complaint, the surgery scheduler will be able to determine which of the choices above apply. This is the conclusion of our presentation. In order to measure the effectiveness of this training, you will be asked to complete a 10-question quiz, which may be obtained from your manager or center director. Please complete the quiz, then submit to your manager or center director to obtain credit for completion of this education. If you have questions, please email questions directly to compliance@thecesgroup.com. A reply will be sent to you in writing.